As a doctor, I've had more than 10 years interest in supporting patients to reverse their type 2 diabetes. One of the key areas, or one of the key jobs of me as a doctor in that space, is to not only give people the confidence that their condition can be improved, but also to make sure it happens safely. And one key area of this is to make sure medication is adapted appropriately. So for patients with type 2 diabetes on diabetes medication, who then go on to change their diet and specifically lower their carbohydrate intake, there are some medications that if they weren't adjusted, they could cause the person harm, either by making the blood sugar go too low or some other serious health conditions, something known as ketoacidosis. So I've learned this over the previous 10 years, and my focus as a doctor is always to make sure that patients don't come to harm where possible. And this is a really important area for everyone involved in this. What I've learned over the 10 years, though, is not everyone has my interest and passion and focus on supporting type 2 diabetes reversal. So I've got colleagues and friends who are doctors who they don't have the time to fully understand what should be done with medication. And this was a barrier to patients. So patients read that they could reverse their diabetes, their type 2 diabetes. They've read that reducing carbohydrate was useful, but then their doctor was cautious because and put caution into them because they weren't sure what to do with the medication. So to respond to that need, myself and a number of colleagues who have great expertise in this area wrote a very short paper aimed at GPs to support what to do with medication when somebody with type 2 diabetes moves to a low carbohydrate diet. And this is just a 2-page article that's open access to the world, but it's focused on supporting GPs. In this article, we really split medication into 2 different categories. One category is medication that must be considered when somebody moves to a low carbohydrate diet, and one category that actually there's no urgency to changing medication, but there may be a benefit to changing in the long term, or the medication may no longer be needed in the long term. So first of all, the medications that we need to pay attention to immediately when somebody changes their diet is medications insulin. So patients injecting insulin, if they reduce their carbohydrate intake, they won't need to be injecting so much insulin. Also, patients on drugs called sulfonylureas, commonly used one is glycoside. These push down the blood sugar level even if the blood sugar level is already low. So when somebody stops eating carbohydrate or so much carbohydrate, if these drugs aren't reduced, it risks the blood sugar going too low. And finally, there's another class of drugs called flozins, and these are drugs that make you pee sugar. And there are some stories out there of patients doing a low carbohydrate diet and taking these drugs that end up with a serious condition called ketoacidosis. So the general feeling was when we wrote this paper for this GP journal was that actually, because the low carbohydrate diet will be fixing the problem, it's probably safer just to stop these flozin drugs and therefore not risk this potentially very serious condition of ketoacidosis. So those are the drugs, those are the only drugs that needed that immediate focus when a patient changes to a low carbohydrate diet. The other drugs are drugs which, again, they pose no risk with a low carbohydrate diet, but it may be they no longer become needed over a number of months or a year or so. And these drugs include metformin, which is commonly taken for type 2 diabetes. It's perfectly safe to have a low carbohydrate diet and take metformin, but you might find as a condition improves over months or sometimes years, then metformin has less use. Another now commonly used drugs are called GLP-1s. They have one role is by reducing appetite. And again, there's no need to rush off these drugs because they may be providing some benefit. But I would expect for many of my patients within 3 to 12 months, it may no longer be needed if they manage to maintain the lifestyle and dietary changes. There's also a group of drugs called glitazones, which are actually very rarely used now, but some patients are still on them. And again, these pose no immediate risk with a low carbohydrate diet. However, typically over a period of 6 to 12 months, they are often stopped because they do carry some other risks with them, and as the condition improves, they often are no longer needed as the dietary changes show their benefit. Finally, there's another group of drugs called gliptins, which again, they're not an immediate problem for any patient with a low carbohydrate diet, but it seems they don't really do very much. So when a patient with type 2 diabetes moves to a low carbohydrate diet, it seems gliptins just don't do much. And what I'll typically do with patients is review them about 3 months after the dietary change and then have a chat about whether or not we want to stop these medications. I don't jump in and stop them straight away usually because maybe they are having some benefit and I don't want to set the patient back before they've made gains. Finally, there is a group of drugs that actually I don't think anyone or very few people now take, something called a carbose. And a carbose basically works by stopping you digesting starch and sugar in your gut. So if you ate starch and sugar and took a carbose, it stops you digesting it and just comes out the bottom end. People don't tend to take these anymore because they cause a lot of bowel upset and wind as the bacteria in the gut digest all this sugar and starch that's not being digested by the body itself. Now, obviously, if somebody's moving to a low carbohydrate diet, this drug, a carbose, stops serving any purpose and can obviously therefore be stopped. But as I said, very few people now take this. So it's an interesting article, hopefully very useful to GPs, and I know of many patients that are supporting their GPs by highlighting this article is available. It's a very straightforward process to adapt medication once a GP understands the basics, and this will help not only support patients with their lifestyle change and improvement, but also, and most importantly for me as a doctor, make sure we avoid harm.